welcome to Parkinson Place Power Hour, and today it's brought to you by Abbott Laboratories. Our topic is advancements in deep brain stimulation surgery, and this is a neurosurgeon's and neurologist perspective. Panelist Barbara Williams, and she's with Abbott Laboratories, and she is also a therapy manager with Abbott Neuromodulation. Welcome, Barbara. Would you like to say a couple of words about yourself?
Thank you so much, Alex. I appreciate it. And thank you all for joining us on this Monday morning. And yes, I've been with Abbott for a while, but I've been working with deep brain stimulation for over 18 years. So it's an amazing therapy for the treatment for Parkinson's. So I'm so glad that everybody could join today to learn just a little bit more from our speakers today, Dr. Gil and Dr. Vivas. So thank you.
We'd like to welcome Dr. Kenneth Vivas. Dr. Vivas is a neurosurgeon and medical director of advanced neurosurgery at Sarasota Memorial Hospital. He received his medical degree and completed his neurosurgery residence from Yale University School of Medicine, where he is director of stereotactic and functional neurosurgery for more than a decade. He's also specializing in deep brain stimulation, otherwise known as DBS, for movement disorders. Dr. Vivas oversees the DBS program at SMH and leads a multidisciplinary team of specialists in the surgical treatment of movement disorders, including Parkinson's disease and essential tremor. We are also joined by Dr. Ramon Gil, a board-certified neurologist practicing in Southwest Florida since 1989. His practice is focused on movement disorders such as Parkinson's disease and related conditions. Welcome, Dr. Gil. Please take it away.
Thank you, Alex. Let me just get the slides here. Welcome, everybody, to this presentation today. I've been asked to review from the neurological standpoint advances in deep brain stimulation as a form of therapy for patients with Parkinson's disease. And what I would like to do is to use one case presentation from our practice to illustrate a patient that was greatly benefited by this therapy. And I would like to share with you how the patient came to us and what the problems that he was facing were at the time. And then I will elaborate in what are, the treatment options and what we did with the patient prior to send him for bilateral deep brain stimulation. So this gentleman was 53-year-old, left-handed, when he came to see us. And this was his diagnosis of Parkinson's was made 7 years prior to his visit. Before he came to us, he had received treatment with multiple medications, including dopamine agonists such as pramipexole, ropinirole, rotigotine patch, and he had all sorts of adverse reactions, anywhere from somnolence to swelling in the legs, confusion, hallucinations, impulse control disorders, etc. Then he was given levodopa, and he came to us on levodopa for 4 years. And by the time he came, he was taking immediate release 5 to 8 times a day. He also reported limited tolerability to rasagiline and amantadine. He experienced orthostatic hypotension and also some hallucinations with these drugs. Because of his physical examination and his neurological problems associated with the Parkinson's, he had moderate to severe resting tremor in his left dominant hand arm. And when he was on, he would experience painful dyskinesias in the left side, more so in the arm than in the leg. When he was off, his tremor was disabling, and he would experience severe anxiety and even panic attacks. He was also reporting body aches and stiffness, and he was forced to retire because of his Parkinson's disease. So when patients present to us with this type of situation, The first thing we need to keep in mind is, yes, the minute you see patients with severe tremor that has failed to be controlled successfully with medications, including obviously levodopa, and when you hear such degree of disability imposed by motor fluctuations and these kinesias, clearly those patients need deep brain stimulation, because you realize that it is impossible to treat these symptoms satisfactorily just with medications. I must tell you that this patient, by the time he came, was clearly past due to be referred to a neurosurgeon like Dr. Vivas that is familiarized and perform this operation on a regular basis. But it will be a mistake to send a patient like this to Dr. Vivas without optimizing his medical treatment. And what we did to achieve that was we switched his formulation from immediate release to extended release carbidopa levodopa, brand name Rytary, which provided a much better symptomatic benefit, longer lasting, and by itself, it reduced not only the severity of the tremor, but also even reduced the hours in the day that he had these kinesias, or as we should say, the patient was able to enjoy more hours of good on time without troublesome dyskinesias. We also introduced GoCobri, or once a day amantadine. As some of you may be aware, this is a new formulation of amantadine that provides much better improvement in the dyskinesias with less side effects than the regular formulation. Remember that these medications that we use, as well as deep brain stimulation, do not provide symptomatic benefit for a lot, if not most, of the non-motor symptoms of Parkinson's. In other words, the problems that this patient was experiencing with pain, anxiety, panic attacks, etc., require other treatments, since deep brain stimulation obviously was not going to address the non-motor, and the value of Rytary and GoCobri were limited in the arena of the non-motor aspects. So we also prepare the patient in terms of the pre-surgical evaluation with imaging, which is a special MRI and CT that are fused, and I'm sure Dr. Vivas will go into more details about that. We also perform a neuropsychological evaluation and his medical clearance in preparation to bilateral deep brain stimulation. And in this case, be aware that the patient needs bilateral DBS because it will be very difficult, if not impossible, to optimize his treatment just implanting a DBS in the right side of the brain to control the left. The left was clearly much more affected than the right side of his body. But if you only do one side, it will be very difficult to treat, if I may say, two patients with the same doses of medication, referring to each side of the body being different, and how could you really optimize the treatment with only one set of dosing. So questions are, who should consider DBS? In general, the first thing to explain to you is that there is no need. As a matter of fact, it's a mistake to think about DBS as a last resort. You don't do DBS just because nothing works. You don't do DBS when the person is so disabled as this patient was. You do that earlier. And the neurologist working with you should be very sensitive to this, in the sense that early on, when we are dealing with, for example, tremor predominant patients, we know that the medications are not going to provide optimal care of this problem in up to 25% of the patients. So why to delay the evaluation and referral for DBS? The other thing is, in general, patients with motor fluctuations, dyskinesias, and tremor are all excellent candidates for this modality of treatment, especially in patients that, again, you cannot satisfactorily control these symptoms with medications only. The way I think about DBS is a treatment not really to, quote unquote, treat the complications of Parkinson's. I believe DBS is a way to optimize the treatment. Or keep in mind that DBS does not address, or should not be seen as something to address the non-motor problems. By that I mean the anxiety, sleep disturbances, the problems associated with, for example, bladder dysfunction, hypotension, etc. And there is limited value in terms of balance. We could discuss that in more detail later. Now, one very important thing is, when you refer a person to DBS, you should have that patient in best medical therapy and optimize. And the definition of best medical therapy will require entire presentation. I don't know how many of you are aware of all these new drugs that we have available for the treatment of Parkinson's disease. I know that you are often lectured virtually or in person at your facility, but I don't know how many of you are taking advantage of all these new drugs. So just keep that in mind, okay? Now, deep brain stimulation in tremor predominant Parkinson's is, without any doubt, the way to go. And that's particularly important for those patients that are diagnosed in the 50s and early 60s. The younger you are, the more tremor you will have typically as part of your Parkinson's. Those are patients that they don't need to go through years and years of all sort of drugs and side effects from many of them, especially when the dose is pushed high enough, trying to control the tremor to satisfaction. They should be considered early on for DBS. There is also increased body of evidence, especially, how can I say, especially supported by the data published by the group from Vanderbilt University in Nashville. They recently reported their study demonstrating significant benefits in patients with early Parkinson's disease treated with DBS. And what they did is they compared patients who were diagnosed with Parkinson's within 2 years of the time that they were implanted with bilateral DBS. And they were compared with similar patients that were managed only with best medical treatment. And at the end of 1, 3, and 5 years, the group with DBS was clearly better than the group with best medical treatment. And this better not only applies to the symptomatic control of these patients, but when they were examined off medication, off DBS versus off medication, the patients with DBS had progressed less into the disease than the group treated with medications. That is remarkable because that is again solid evidence that DBS may have some sort of disease modification benefit. So the benefit of DBS is not just symptomatic. This type of evidence was also presented by 3 previous large studies, which were conducted years ago, Europe, United States, and Canada. And the studies were not designed as the one in Nashville exclusively to monitor what will happen at the end of the day with the 2 groups. They had other sort of outcomes, but interestingly, they all monitor quality of life. And in all these cases, quality of life was better in the group that was operated versus the group that only had medical treatment. The last one of those large studies was the famous VA study conducted in this country under the VA administration support. And one of the ideas was in that particular one to decide which one was better as a target, GPI versus STN, which are places that Dr. Vivas will explain to you in more details. But in that study, as they were monitoring the course of these patients with DBS and medications versus versus medications only, the evidence in favor of DBS was such that the study was suspended halfway because it was not ethical to continue keeping patients on medications only, knowing how much better the other group was. So that gives you an idea of how life-changing experience you could have with deep brain stimulation, again, for the right patient at the right time. And one final comment about this, I am not advocating and we are not saying that everybody needs DBS, and we are not saying that patients need DBS within the first 2 years. This study comes to bring light to one area where we are still learning, which is the, if I may use the term, neuroprotective, or the term disease modifying benefit from DBS. And a quick run about something that you all know better than most doctors. There are at least 7 to 10 million patients with Parkinson's disease in the world. And you all know that Parkinson's disease is increasing rapidly in frequency around the world. As a matter of fact, as per today, we know that it is the fastest growing neurodegenerative disorder around the world, faster than Alzheimer's. And in this country, there are at least 1 to 1.5 million patients with Parkinson's disease. So this is something that we need to take very seriously. We need to improve our diagnostic techniques. We need to increase the awareness, not only among you patients and family members, but also among doctors. You all know the typical signs of Parkinson's disease: slowness, rigidity, tremor, changes in gait pattern, etc. And you know that there are motor and non-motor symptoms. And the non-motor symptoms are very important for many reasons, including the fact that they are present, many of them, before the motor symptoms. So hyposmia, or changes in the sense of smell, and constipation, for example, precede the motor symptoms by 10, 15, 20 years. Sleep disturbances like REM sleep behavior are also very common prior to the motor part of the Parkinson's disease. Anxiety, depression are present in at least 50% of the patients with Parkinson's disease prior to the diagnosis. And we believe that at least 75% of patients with Parkinson's disease will experience depression and anxiety to the point of requiring medical treatment. Then we also know that the progression of the disease leads to many other potentially disabling problems like cognitive impairment and dementia, but also balance, falls, etc. Many of these things are able to be delayed or minimized with early interventions like those amazing programs of exercises that you get through your program there at Parkinson's Place. I encourage all of you to start your yoga, tai chi, exercise, dancing programs from day one. Don't wait for your balance to be impaired. Don't wait for you to be in need of a cane or a walker to start dancing, for God's sake. Do it early on so you may never need a wheelchair or adaptive equipment. Now, as the disease progresses, we know that patients will have a gradual loss of the benefit received by the medication, which is what we call wearing off or off time. And these fluctuations tend to increase and become increasingly more and more disabling. And then the on state is when patients are enjoying the symptomatic benefit of the medications. These problems of motor fluctuations are associated with another motor complication called dyskinesias, which are these involuntary twisting, dancing-like movements, often associated with facial grimacing, and they could be rather disabling or embarrassing for many patients and family members. So this happens to be one of the most significant reasons why patients need DBS to optimize their treatment. And I believe that this is the time in which Dr. Vivas take over, or am I supposed to continue this part? Hello?
Yes. Hi there, Dr. Gil. I believe that Dr. Vivas is going to come on soon, but we do have a question for you.
Yes, ma'am.
So let me just start my video. Hang on one second.
You want to start this video here? Okay. So the patient is on. You see a slight tremor. Look at him with very, very good motor skills. And now look at different he is when he is off. The tremor is more prominent. Okay, he still has a good mobility. Remember, young patients with Parkinson's have more tremor, but they walk better and they have less slowness than older patients. And these are dyskinesias, involuntary movements, which could be ballistic, like he did with the arm, or choreiform, like dancing. See, that was a ballistic type of dyskinesia. Okay, so you'll see here. Okay, these are the motor fluctuations that I was describing to you. And these ups and downs reflect the increase in the concentration of levodopa in plasma at the same time that the symptoms improve. And then the concentration of levodopa decreases, and then patients are more symptomatic or off. And this is much easier to treat now with medication than before. We could discuss that at a later point during the presentation. And when the levels of levodopa reach this level here, these kinesias occur. So we are supposed to keep patients within this therapeutic window in which they are on, but without these kinesias. But this therapeutic window, as the disease progresses, narrows down with the level of levodopa in plasma required to go on increasing and the dyskinesia threshold decreasing, so the window is narrower. And here you have another way to display or explain this problem or this challenge that we have. Now, you are all aware that the symptoms of Parkinson's disease are caused by loss of dopamine in the brain, since the cells that produce dopamine in the back of the brain are dying. And by the time a person demonstrates the motor symptoms of Parkinson's, 60 to 80% of those cells are dead. And there are many other chemical imbalances in the brain, not just the acetylcholine, but many others, serotonin, noradrenaline, glutamate, adenosine. So this is a very complicated condition. And how we diagnose patients with Parkinson's disease? Well, we identify at least 2 of the 3 major signs of, at least 2 out of the 4 major signs of Parkinson's: slowness, rigidity, tremor, and changes in gait or balance. Early on, we do not include gait, balance, falls, because those things don't occur early on. So a person that comes with early Parkinson's disease, we need 2 out of the 3 major ones. And there is no simple blood test to identify Parkinson's. I will tell you, however, that we have made a lot of progress in terms of confirmatory testing, not only with the DAT scan, but now we also have available a skin test called CYN1 test that confirms the presence of alpha-synuclein in the skin nerve fibers, and that is diagnostic of Parkinson's under different circumstances. I could explain it to you later. Be aware that not everybody with signs of Parkinson's has Parkinson's disease, and that's another whole presentation or agenda. And this is the imaging of the PET scan, and the DAT scan, showing here a normal activity of the dopamine in the brain versus a patient with Parkinson's with reduced activity of dopamine in the brain. And we are also able to use a levodopa challenge, and there are ways to do that and pros and cons, which we could discuss later. And obviously, the most important thing is for your doctor to be able to quantify your Parkinson's, which there is a scale called the Unified Parkinson's Disease Rating Scale. Then you quantify, especially the Part 3 or the motor assessment. And then when you receive medications, let's talk about levodopa in particular, you should be able to demonstrate at least 30% improvement, and that will be diagnostic of Parkinson's disease. One of the things that we do working with Dr. Vivas and other neurosurgeons before the operation is conducted for DBS, we examine the patient off levodopa and on levodopa. And the higher the percentage of improvement that they get, the more benefit they should expect from the DBS. And there are many different medications that we could use to treat Parkinson's. Levodopa is the gold standard. Levodopa basically is transformed into dopamine in the brain, and then the deficit is minimized. COMT inhibitors are drugs that increase the availability of levodopa to the brain. Dopamine agonists are drugs that look like dopamine and they work like dopamine in the brain, and they have different advantages and disadvantages when compared with levodopa. And then we have MAO-B inhibitors that are medications with limited uh, symptomatic benefit, but they seem to save your own dopamine, and they also seem to prolong a little bit the duration of benefit of levodopa. The limitations to treat Parkinson's with medications by mouth is, number one, that you have a lot of problems in the stomach and the intestine caused by Parkinson's, and there are a lot of limitations absorbing the medications, and the motor fluctuations are also unavoidable in Parkinson's. And the higher the doses of medications, the higher the incidence of side effects. Polypharmacy could be a big problem for many of you, especially older patients with the disease. And this is repeating what I just said before with my case. So I think that now we're going to leave this to the surgeons. One more question, one more point to make for you guys. Dr. Vivas is the surgeon, and he is great. But the success of surgery starts with patient selection. Patient selection is critical. So your neurologist is the one that should be best to advise you, you are or not a candidate. Now, Dr. Vivas have a huge responsibility because he is the one placing those leads in the perfect location. So like in real estate, location is the hit for success. So with you guys, Dr. Ken Vivas.
I'm going to be talking about the actual surgery portion of the surgery of the treatment itself. And this is just an overview of how this all works. So deep brain stimulation, we send some electrical impulses delivered via a generator and a wire to a very specific part in the brain. And as Dr. Gil said, it's all about location. My task with patients is to identify the ideal place in the brain to place the electrode in order to maximize the amount of therapy we can give, and at the same time minimize any side effects or other problems that might occur while we're giving the therapy. And so there is a small hole made in the bone, which is then later covered with a plastic device that holds the electrode in place. And the electrode is lowered into the brain after we do some mapping. After all of that set at a different time, then we hook up this wire that goes underneath the skin. Just to remind everybody, I get that question a lot, is that all of it is underneath the skin, and it comes down, and then the generator itself is implanted in the chest, and that's what actually provides the stimulation. Here it says that it stabilizes brain signals that cause involuntary movements. And in truth, it's a very complicated situation in which it works. We see some effects that occur immediately when we turn on the generator. And then there are some things that we see that only occur over a longer period of time of stimulation. And both of these aspects are very important in the success of treating with this type of electrical stimulation. There have been a number of advances over time, and Abbott is the sponsor of this talk. And so I'll be referring also to some things that have changed over time. DBS was first approved through the FDA for the treatment of essential tremor in 1997, and later in 2001 for Parkinson's disease. So this therapy has been around for a while, but there have been recent advances in the way we can perform the therapy that make it even better for patients in the long run. So what can we do with deep brain stimulation, and what are we hoping to do? As Dr. Gil referred, there's a lot of motor fluctuations within Parkinson's disease, especially once you begin treating with patients with a combination of levodopa and carbidopa. And so what we're hoping to do with DBS is to increase the number of hours each day that's spent in that good window of quality on time. And we want to reduce the amount of time that you spend in the off time, and also try to reduce the amount of time that you spend in the dyskinesia time, and overall reduce the amount of medication that's needed to allow for a more fluid day. One of the other things that we saw on Dr. Gil's slide is that as Parkinson's progresses, the amount of fluctuation that occurs during the day increases as well, so that there are more cycles on and off. So a patient may start with only having to take their Cinemet 3 times a day, but over time, they are having to take it more and more frequently because they're going in and out of that therapeutic window. And if we can make it so that even if there is some fluctuation, it occurs less often, that's also oftentimes considered a success with many patients. So Dr. Gil said, which he's absolutely correct, that it's all about choosing the patients and making sure we're going to pick patients that are going to get better with deep brain stimulation and not end up implanting patients which we're pretty sure are not going to improve. And so the FDA labeling is for patients that have been diagnosed with Parkinson's for at least 4 years. And even in our early studies where we talk about early treatment with deep brain stimulation, 4 years is about the right cutoff time that we want to see that patients have been having Parkinson's disease and trying to achieve optimal medical therapy. We usually have a few different things that we look at specifically in patients to make sure that they're going to have a good success with deep brain stimulation. And most of these patients are dopamine responsive. I should correct that. It's all of these patients are dopamine responsive. That's one of the kind of screening things that we look for. If you don't get better when you take your dopaminergic medication, you're probably not going to get better with deep brain stimulation. And I'll talk about that a little bit more. We're usually looking for these primary motor disturbances that we see in Parkinson's disease with the slowness of movement, rigidity, the stiffness, and the tremor that's associated with Parkinson's disease. And as far as the gait difficulties, I'll talk about that a little bit more as far as how we see that improve and what type of gait difficulties we absolutely know will not improve. Many patients oftentimes will have these troubling dyskinesias like we saw, but not all patients that come to me and are treated successfully are in that stage either. And we're seeing these motor fluctuations. As Dr. Gil said, though, with some of our newest medications, the amount of off problems have been reduced, but many patients still experience a lot of problems with motor fluctuations during the day, even if we're starting them on some of these newer medications that can be given, even via inhalation. We have to very carefully make sure there are not other mimics of primary Parkinson's disease. And this is just a list of some of those things that we have to think of and make sure that patients do not have before we consider using them for surgical therapy. And we're also carefully screening patients for evidence of dementia and depression. And now this is somewhat controversial as far as the dementia aspect goes. We certainly know from our early studies that many patients that had dementia and were implanted did not do well. We also know that a lot of the more recent studies eliminated those patients completely from the study. And so we don't really know what might happen with them. And from my point of view, I don't use an absolute number as a cutoff of a certain scale to say that the patient is not a good candidate with dementia, but it's really kind of how their dementia may manifest and how they interact with their family and what their disease is like. And so it ends up being very individualistic in patients that have cognitive difficulties to make the decision about surgery. Depression is important during screening as well, because there's one of the few good hard evidence that we have where we might want to consider a different site for implantation over another, which is specifically in patients with depression. So when we're looking at patients that have uncontrolled symptoms, we're really waiting until they're in this window of moderate to advanced symptoms. But we're seeing patients all the way at this edge of the bracket and all the ways over here. Patients that have very, very severe symptoms, they're oftentimes still able to be helped by deep brain stimulation. But if you get to the point where you're no longer responsive to your carbidopa, levodopa preparation or other dopamine agonists, it's probably at the point that so many of the dopaminergic neurons have been lost that we're probably not going to be able to treat you with deep brain stimulation either. We talked a little bit about how you end up coming to see me and what the screening process is like, but it's absolutely essential that there is a movement disorders and a neurologist involved in your care. Sometimes I get patients directly from general neurologists sent to me. And before I kind of move on, then I have them see a movement disorder specialist, unless they have some, very specialized experience in patients with Parkinson's disease, because, oftentimes, especially with the medical management and me knowing that they are medically optimized, I'm not a neurologist. I am not Dr. Gil. I need his help in making sure that there isn't something that we haven't thought of that should be tried before moving on to surgery. I always start off my visits with patients in talking about their symptoms. I kind of ask a little bit about their history. And my very first question is what is it about your Parkinson's disease that isn't being well treated with your medications that you hope that I can help you with? And I have a detailed conversation about what are the problems that they're experiencing in their life and what do they really want to have changed. And then together we talk about whether or not deep brain stimulation can help with those symptoms. Once we get past that part of it, there's some additional testing that's done. We do a specialized type of MRI scan that allows me to see certain anatomic structures, as well as providing a map to get down to the proper area that we need to get to in surgery. And we do, as Dr. Gil said, the neuropsych evaluation, looking for dementia, depression, and also getting a baseline of what your speech is like, because that's important because of that's one of the side effects that we sometimes see with deep brain stimulation is an effect on the fluency of your speech. Once we have this all together and everybody's in agreement to move forward, we move into the surgical pathway to get you actually implanted. It usually takes somewhere around a month between the decision to schedule surgery and the actual surgery itself. This whole problem with COVID has thrown this off, in ways I'd never imagined more recently. But thankfully, we're back on track here in Florida, moving forward with surgeries. And again, taking about a month between deciding to do the operation and actually getting you into the operating room. I have found over time that for patients, especially with Parkinson's disease, unless you're especially young or a certain circumstance, it's better to only do one electrode at a time. And the reason for that I have found is that we need your feedback during the operation. You're telling us about side effects that you're potentially experiencing, and you're participating in showing us what your symptoms look like. And you're great during that first electrode placement. But by the time I'm doing the second electrode placement, and I am on the very quick side as far as doing the operation compared to many other people, and certainly compared to the people that train me, but I still find that by the time I'm doing the second electrode, that most patients are not really able to participate in the same way they did with the first electrode. And that makes me feel like I may not be able to get it in the most optimal position for that patient if I try to do it at the same time. So I usually do only one at a time. The first operation, where we place the electrode in the brain, is done under local anesthesia with some sedation. You stay overnight in the hospital, and then you're home the following day before lunchtime. About a week to 10 days after that first operation, you come back and I put you under general anesthesia, and we place that second part. We place the connecting wire and the generator in the chest. That has to be done under general anesthesia because it's kind of painful to tunnel underneath the skin, and there's no way of really numbing all of that up with local anesthesia. And so we put you to sleep. If I did this general anesthesia right after I did the first operation, it kind of makes the whole operation too long, and then you're recovering for both the placement of the electrode and the general anesthesia. And what I found is that I can't get people out of the hospital the following day. And I feel that it's essential to get people out of the hospital and have you be there for the shortest amount of time, because you don't end up taking your medications or doing the activities you normally do with Parkinson's disease while you're in the hospital. And so the longer you're in the hospital, the worse off in general you are when you leave. So just quickly to summarize that again, we plan and place the electrode. The electrode is refined at the time of the surgery by having you awake and listening to the firing pattern of the cells and mapping things out, which I'll show you. And then as a separate date, we bring you back and we place the generator and battery. And again, that's done as an outpatient. You go home that same day, and then you follow up in the neurologist's office where he does the programming, he or her. So again, just to go over what we do during the lead placement is we first plan out the target using a combination of a CT scan that we get with the frame on the patient's head and merged with the MRI scan. We then map out the brain by listening to the firing patterns of the cells with an extremely small electrode. It's finer than the human hair. And then once we find the ideal location, both by listening and by doing test stimulation, we place the lead itself that's going to stay. We lock it to the skull. We do another round of testing and confirmation that we have the ideal spot. And then you recover in the hospital overnight. And this is just what it looks like in the operating room. You know, the patient is here and you're in a semi-sitting position with the frame on the head. And on the other side where I'm doing the work, there is a drive that moves the electrode in and out in a very, very precise manner so that we can do these recordings and listen to the firing patterns of the cells and then do the test stimulation. In the second stage, like I said, we pick up the other end of that electrode that was inside the head, about here, right behind the ear, and then we make a connector. And this wire that then goes and traverses down across your neck where there's movement is a little bit sturdier than the one we have in the brain. And by breaking it up like this, it also allows us to not potentially have to repair an entire system if one part of it should malfunction. And then this, again, this is all underneath the skin, and we place the generator in the chest. And let me just see if that's, yeah. And this is reiterating some of the things. We typically place it just below the collarbone, but we sometimes have to modify that for patients that might have a pacemaker already for their heart, or you know, other issues that might make us move this to a different spot. If you're going to have both leads implanted, for sure, this can be a dual channel generator. We can then bring the second lead into the same generator. And again, it's done under general anesthesia as an outpatient. I'm going to save some time for Dr. Gil to talk to you about what a programming appointment is like. But you know, typically all of the context of the leads are checked, and we try to optimize and find the best combination of contexts to use. We've oftentimes shared the information from the operating room with the programming neurologist, and over time we have to optimize everything for you. It can seem sometimes tedious, but oftentimes actually it can go great as well and be very simple. But there's so many different things that we can change. It does take some time to find the optimal set of parameters for any given patient. And now I'm going to move and start talking about outcomes. And I have about 9 minutes left to try to get through this. So I may go and skip a few slides in the interest of time to make sure that I get to the most important parts. So everybody wants to know, all right, it's great. We have this technology. How well do patients actually do? And here are just some general numbers, is that 80 to 90% of the patients feel that they're improved after implantation of their deep brain stimulation. There's a 60% reduction in medications, and also a 60% reduction overall in the degree of dyskinesias. This can sometimes take some time, especially for oftentimes to get to these things. Both sides have to be implanted and both sides optimized before we start reducing the medications and see the reduction in dyskinesias. There's an 80% improvement in off periods. And you know, your on period is where we want you to be. Most patients that we're implanting still achieve a good on period, but if we can get rid of the dyskinesias, we have an even better on period. And I'm not going to talk about essential tremor today. Here, when we're looking at and seeing what the outcomes look like, the main kind of message of this is that this is maintained in this slide all the way out to 12 months. that the mean dose of levodopa was significantly decreased. We see this most robustly in patients that are implanted in one of the sites in the subthalamic nucleus. And that, by reducing the medication, we're reducing the dyskinesias, and oftentimes the reduction is also means less frequent dosing. And, again, you see that the on medication scores don't look all that different, but look at the dramatic difference in the off medication scores between surgery and after surgery. This shows all the way out to 5 years. I'll show you another slide looking out even further. And again, the duration of the dyskinesias is significantly reduced after the surgery all the way up to 5 years, going from a duration of 2.1 hours down to a duration of 0.6 hours. Looking specifically at some of the newest technology that Abbott has provided, we look and see that with this new technology that 90.6% of the patients had a bigger therapeutic window. As we were talking earlier, we have more options and a bigger window in order to be able to make changes and not cause side effects with this new technology. In addition, we see that there's been, again, a bigger therapeutic window, but also a significant reduction in the amount of current that is being used to achieve this. So a significant reduction in the amount of energy that your battery is having to put out. And this in turn will increase the overall battery life over the lifetime of the generator. I should have said before, in general, on average, a battery lasts 4 years. And this is kind of before this newer technology. Now we're seeing patients out 5, 6, 7 years with this newer technology and not having to replace the generator. Even when we do have to replace the generator, it's like a 15-minute procedure. We pop out the old one, we put in the new generator. It's done under local anesthesia with just some sedation. So, yes, this is all, we're talking about this increase in therapeutic window. So certainly the data shows that clinicians prefer the fact that we can use this special technology, and it's called directional stimulation. Instead of providing the stimulation circumferentially around the tip of an electrode, we can just use one segment of the electrode. And that allows us to target fiber bundles in one direction instead of the other direction, which is very complicated for you as a patient, but for the clinicians really preferred this significantly over other technologies. But do patients prefer it? Yes, indeed. Twice as many people of the patients in this study preferred the directional stimulation because of the reduction in side effects and other issues compared to the previous technology. And again, we'll see that out at 12 months in this particular study, that there's a 40% improvement in patients that are off meds. And in fact, now a 44% improvement even on medications when the stimulation is on as well. So we're seeing a lot of these dramatic improvements in patients over time. But, as I said at the beginning, it's now been, 20 years since we were implanted the very first patient. And this is a study that came out of Grenoble in Dr. Benabid, where these first patients were implanted and a lot of the original studies were done. And they're looking now at a mean follow-up of 17 years after the patient was implanted. And, we didn't know. We thought for sure, as Dr. Gil said, is that the patient's Parkinson's would just continue to progress. We did not expect to actually see that we were making a change in the progression of the disease. But, if you look at this data, really 15 years out, there's still a significant reduction in the time spent with dyskinesias, a 75%, a reduction in the time spent in off state, a decrease in the amount of drugs that were being used, an improvement in patients' social function and emotional function and their quality of life. And what's not on this slide is that, the amount of energy that we end up using in patients, even 15 years out, it's not that different than what we used initially. If the patient was truly progressing through their Parkinson's disease, the expectation would be is that we were having to use more and more energy over time. And in fact, it stabilizes after the first couple of years, all the way out to 15 years after the implantation. All right, so this is all great. What are the risks associated with this? And this is a good slide, mainly to also remind you and me that the number of side effects in the original papers was higher than what we see today. So when we look here down, there was 234 patients included. There were 12 events in 12 different subjects. 5 of these were things that were reversible and or able to be get around with medications or changes in the way we were doing the programming. And so there was one patient with some cognitive problems, one patient that had some problems with their speech, another one with their swallowing, worsening of some of their symptoms, and one that was having increased problems with dystonia, all of which could be fixed over time. In fact, there were no patients that had the most feared complication of intracranial hemorrhage, no patients that had infections, and no patients that had a problem where the wire became problematic in the neck. There were some an erosion and some swelling and some other problems associated with the device itself. And this is reflective of my own experience as well over time. So just personally, I've only ever had 2 hemorrhages in patients, and one of them was not clearly related to the actual placement of their electrode. It occurred several months afterwards, and they developed some bleeding on the surface of the brain, but it was on the same side. So certainly you have to think about that. And I had exactly one other patient who ever had any bleeding in the brain during the electrode placement, who eventually did fine and got good use of their electrode. And this is in over 1,000 electrodes that were implanted either for deep brain stimulation or for epilepsy. So that's a lot of patients with very few side effects overall, and certainly a very rare case of having bleeding into the brain. The one other thing that we really want to we're excited about that has come with this new technology from Abbott is increased ability for the patient to interact with their stimulator, but most importantly, also an increased ability of the programmers like Dr. Gil and other people to be able to do remote programming. If anything, what we've learned during this period of time with COVID is that patients want to have the option of not having to come to the office. Many patients live far away. I see patients that are, as far south as Naples. They don't want to have to keep coming to my office for all sorts of different things. And I'm sure they don't want to have to necessarily keep coming if they're having a problem and need reprogramming. And so even patients that are implanted with a different brand now can potentially be use Abbott's technology and allow remote programming to take place for those patients. And again, this is just another look at this new technology where we have these 2 central electrodes that are divided into 3 different segments instead of a single segment. And that allows us to do this directional programming and also allows us to reduce the amount of energy that's being utilized. And again, there's this, all sorts of things that could be done with the programmer for the clinician, which has a lot of interesting ways of us visualizing and thinking about individual patients and a lot of options using just your own phone to be able to interact with your implanted device. And then just lastly, here's just a little depiction about changing this and using directional steering to drive the amount of energy being applied in the brain in a certain direction.